Well, I'm happy to get started. I've met many of you, but for those of you who don't know me, my name's Namita Goyal. I know I look young, I've been hearing that, but I've actually been taking care of myositis patients for 17 years. I started my career at Harvard and learned a lot from my colleagues who were at Harvard. Dr. Amato, Dr. Greenberg are some of the leaders in the field in IBM. And it's actually where I became passionate about IBM. And I thought, we're curing cancer these days, and how do we not have a cure for one of the most common muscle diseases? And it's really become a passion of mine to find better therapies for our IBM patients. I don't accept that we don't have a treatment. I don't think that's even right to even talk about. And so me and my colleagues do look for better options, better treatments. But in the meantime, what the purpose of this session is, oh, sorry, I'll let a few more people come in.
Can't do that.
Feel free.
Make it.
You might, do you want to come up through here? Yeah.
That way I can cross from there.
Yeah, great. Yeah, and so, this session, what I wanted to focus on was, sure, there are advanced stages of IBM, but what really can we do to prevent those advanced stages? And I do believe there is, while sure, we don't have a magic pill yet to stop or slow down progression, I really truly believe that there are a lot of things we should be doing and can do to slow down progression just medically with you and your care team. And so that's what I really want to highlight today. And I think a part of getting to how can we reduce that disability and those complications is understanding IBM. And I know you all here probably understand IBM and live with IBM, but to even just educate ourselves about the clinical features, the understanding of what's happening. I think one of the challenges in IBM that we were even talking about at lunch is the average patient takes about 5 years to get a correct diagnosis of IBM. And what can we do to actually make that earlier? Because I truly believe that intervention started early will even help reduce some of these complications. I'm also of the belief that it's never too late. So regardless of where you're at in your stage, we don't stage IBM, but wherever you're at, all of these things I'm going to mention about multidisciplinary care will have an impact on your disease. So just some basics to start with, but many of you know that IBM is the most common acquired muscle disease over the age of 50. It's often characterized by slow progression of muscle weakness and atrophy that affects the quadriceps muscles, so the muscles in the thigh, but also the muscles in your fingers and your grip muscles. Over time, all skeletal muscles can be involved so that you lose almost complete finger flexion, walking difficulties, swallowing difficulties, and like Dr. Mozafar mentioned earlier, even facial muscles can get weak in IBM. Not all of this happens all the time, which is why I've been starting to think about IBM as an umbrella of a disease, and maybe we have subtypes and spectrums of IBM, and I think we're going to understand this more over the years. Some of the common symptoms that we'll see and hear about are falls. So falls, if you think back in your history, without even obvious muscle weakness and muscle atrophy, we see muscle wasting, falls, gait difficulty, difficulty even climbing stairs. Some patients will develop what we call a foot drop, where the foot at the ankle gets weak, and so it can catch and that's where the tripping and falling can happen, or even knee buckling. So a lot of you have experienced falls that just came out of the blue. Your knee buckled and you just gave way. And why did that happen? It's because of that quadriceps weakness. So even you understanding those elements of your body can be insightful into what can we do to prevent those falls and the gait difficulty. Is it okay if we close that? I was just, we're hearing the other speaker, and I think.
Yeah, some more coming in.
Oh, no, great. That's great. But grip weakness is also something that you might recognize. It can even start with manipulating keys, manipulating fine objects, zipping objects, putting your pants on, grip difficulty. Many of us will talk about it's hard to open a jar. Carrying heavy objects over time can be difficult when the upper arms get involved. And then swallowing difficulty is also an underappreciated feature, I would say. It's not always present in IBM, but the literature reports. So Dr. Mozafar and I wrote an article on swallowing difficulties in IBM, and I reviewed all the literature that's ever been published. And you see varying reports of swallowing difficulty from as low as 30 to 40%, to as high as even 80% of IBM patients have some degree of swallowing difficulty. And one of the most important questions that if you think, oh, well, I have no swallowing difficulty, or when I ask patients and they say, nope, my swallowing is fine, usually one of the most sensitive questions is, do you have a stuck sensation when you're swallowing? That might be one of the earliest indicators of swallowing issues, and over time that may worsen. And so it's important to understand that because we want to look at maneuvers that could help swallowing, and I'll talk about that in a few slides. But if you have significant swallowing issues, that actually puts you at risk of aspiration pneumonia, which then becomes an important feature that can cause comorbidities or illnesses in IBM. And then there's this bucket of underappreciated, underrecognized features that sometimes when you talk to your IBM specialist, they might just chalk it off or dismiss it. But we do appreciate this in IBM, that IBM patients, a lot of them will just describe overall fatigue. They just don't have the energy that they had to do these activities. Some patients will even have a little bit of a neuropathy or numbness in their feet or hands, and that we do see in IBM. And then pain, you know, a lot of people think IBM is painless, it's a muscle disease, and your neurologist or rheumatologist might say, oh no, we don't see pain in IBM, but we actually did a survey a few years ago, and we're actually surprised by the number of IBM patients that did report pain, and we do think this is an underappreciated and underrecognized symptom. So I just want to validate some of the symptoms that you have and think about that, yes, we do see this. And then asking yourself if you have shortness of breath. So shortness of breath can occur from diaphragm weakness. And sometimes it manifests only when you're lying flat or sleeping. Sometimes it'll manifest when you're doing certain activities. But those all could be signs of diaphragmatic weakness that does have treatment for it. So like I mentioned, the reason I wanted to talk about diagnostic evaluations is because I do believe that earlier diagnosis does help and impact the disease. And so just some things to think about if you haven't had these evaluations, but these are a number of tests that we do look at in IBM. And I'm going to go through each one of these points. So muscle enzymes, we know in IBM can be elevated, but importantly, they don't have to be elevated. So what I'm circling here is the variation in reports in the literature about how muscle enzymes can be normal or they can be up to 1,000. Generally, if they're over 3 or 4,000, we don't typically see that in IBM, and that's when we do entertain other muscle conditions. So just some food for thought. And then you've been hearing a lot about muscle biopsies, and these are some of the pictures of muscles that we see in IBM and some of the classic features that are discussed as part of your diagnostic criteria. So endomysial inflammation just means we're looking for inflammation in surrounding a muscle fiber. Many will talk about rimmed vacuoles, and those are the blue image where you see these white spots or little holes in the muscle surrounded by a red discoloration, and that's protein accumulation or rimming of those vacuoles. And then inclusions are seen on a finer electron microscopy. Now, the reason I mention all of these is because the gold standard still is, in order to get a diagnosis of IBM, you have to have one of these features seen on the muscle biopsy or more to get that diagnosis. But what's important to note is that this was published back in 2015 from our colleagues from the Netherlands, but they actually found that up to 40% of IBM patients don't even have the classic rimmed vacuoles that we look for on muscle biopsy. And I think this was important, an important marker, because a lot of neurologists would say, or even rheumatologists would say, well, I'm not comfortable giving you the diagnosis of IBM because you don't have that classic feature. So we are trying to broaden the inclusion criteria for IBM so that patients get earlier diagnosis. Now, you've probably been hearing about the blood test in IBM. This was discovered in 2013. It's the NT5C1A antibody, and it was shown to be seen in about 60 to 70% of IBM patients, but subsequently we saw a wide variety of reports saying, well, maybe we see it in 30% of IBM patients. Maybe we see it in up to 80. So that debate is still out there, and we're still trying to answer that question of why do some IBM patients have this antibody and why do others not? But what's important to note is that it does have high specificity, over 90%, which means if you have the autoantibody or this blood test being positive, the likelihood of you having IBM is much higher. Now, I'll just mention that there have been some reports of this antibody being seen in Sjogren's and lupus patients, but at least in the lupus patients, we haven't seen the typical pattern of muscle weakness that we see in IBM patients. And so we don't think those patients actually have IBM. What's also important to note is just a very small percentage of patients in other subtypes of myositis might have the antibody. So my point is that if anyone is carrying a diagnosis of polymyositis, you do want to test for this autoantibody, because if it's positive, it actually might be IBM and not another subtype of myositis. And then lastly, I've been very interested in muscle imaging, and there are some really nice studies in how muscle imaging can help either recognize IBM early and also pick the right muscle to biopsy. So I'm hearing about a lot of stories about I had 1 to 3 muscle biopsies because they couldn't find the right muscle to biopsy. We now use muscle MRI to help us understand, is this a good muscle to biopsy? The other important thing is that we're also using muscle MRI to look at the pattern of which muscle is involved. So on the left, what you're seeing is a cross section of a forearm, and the white is abnormal muscle. So the black areas are very normal looking muscle, but the white where the arrowhead actually shows the finger flexor muscles in this patient are severely affected, but all the other muscles that cause hand movement are not affected, a pattern that is typically seen in IBM. And similarly, on the right, you see a cross-section of a thigh muscle MRI. And what you're seeing on the outer edge is the quadriceps muscle where the arrowhead is, and that's completely white, showing severe muscle damage, but you can see other muscles in the thigh or in the posterior compartment in the back of the arrow is actually not affected. And so these patterns have been well described, and oftentimes if someone is going through a diagnosis and we're not quite sure, or they didn't have the muscle biopsy features, we actually do muscle imaging to help us see, do they have the classic pattern that would fit an IBM patient to even avoid another muscle biopsy. And then this is an example of a patient. So here the muscle MRI is looking at the arm this way, sort of exactly parallel to the hand that you're seeing. And this patient had very mild grip weakness. You can see that he can still make a grip, but maybe the tips of his fingers were just slightly weak because he couldn't really bury them into his fist. Well, what we did was a muscle MRI, and again, it highlighted the finger flexor muscle involvement. So we've been using that a lot to help an earlier diagnosis of IBM patients. But let's talk about management, because that's what we really, want to help and intervene with our patients. And we've been talking a lot about treatment. So this is disconnected, but okay. We've been talking a lot about treatment, and one important thing to realize is that we still don't have an answer as to what causes IBM. You're hearing a lot about the complex nature of IBM, but really we think it's possibly a complex interplay of cellular stressors, inflammation on one side, and degeneration, which is why maybe we're seeing it in older patients more than, our 20 and 30-year-old patients. But the key question that has remained is inflammation the primary cause and then the muscle degenerates? Or does the muscle degenerate and then inflammation comes in to sort of attack the degenerating muscle? We still don't definitely know. However, we are wondering if inflammation is the primary driver nowadays of the disease. And it's saying Zoom is not working here, so I'm just, okay. So this is just a slide to show you, I know in some of the prior sessions we talked about treatments. What I listed is here are all the different clinical trials that have been done in autoimmune immune suppressant medications, including IVIG. They've been systematically tried and looked at, and unfortunately, no drug has, at least collectively in a large patient population, shown to either sustain, improve, or robustly impact IBM. And so that's why we have looked at more standard of care in terms of multidisciplinary care to help our IBM patients. But there have been a lot of questions on, well, what's the rate of progression? And so I wanted to review some of the studies that have been done that look at rates of progression and what can we expect. I'll tell you that all of these studies are unfortunately very small. So whenever you have a small study, those results can be skewed by one patient outlier or a few patient outliers. So it's hard to make generalized impressions of it. But still, this is the data we have, which is again why we've been really pushing for this natural history study, because our study that we're doing at Irvine and with other centers is planning on enrolling 150 patients. But for every study that I've listed here, I just want you to see that we're talking about a small number. So on the left, you see that only 15 patients completed this 12-year follow-up. And only 23 patients on the right completed the 1-year follow-up. But what the data looked at was what do we know about muscle strength? Well, when they evaluated muscle strength, they saw that on average, patients had somewhere between a 3 to 5% decline in their muscle strength annually. Again, this is just based on the data that we have. Interestingly, this study, again, on the right, you'll see it's 16 out of 22 patients completed a study that was just 9 months long. But what I highlighted was this third column, which looks at the percentage change that happens to muscles in 9 months. And you can see of all the muscles in this column, the percentage decline, the quadriceps muscle had the largest decline of all the other muscles. So, for instance, hand grip muscles declined by about 4% in strength. Some elbow muscles declined by about 5 to 6%, but the quadriceps muscle annually declined by about 12% in strength. So when you think back to your own body, you can appreciate that, yes, certain muscles had more of an impact and declines, while some of the other muscles remained stronger than some. So I do think this is interesting data. In the prior session, someone asked about the IBM functional rating scale, and you can see that they looked at it. It's the last row in this, and that's an outcome measure that is commonly used in clinical trials. And you can see that's a 2% decline in the IBM FRS scale in over 9 months. Point being, not major declines over the year if you look at all muscles, but when you look at individual muscles, yes, there are major declines that maybe we're not appreciating. This study I like. This one's a 4-year study, but I don't love it because it's only 13 patients, you can see. But what I want to point out, again, they looked at different muscles. Now, this is changes over 4 years. So when you're thinking about your body, not over a year's period, but about 4-year period, you can see that some muscles, again, have stronger hits than others. And the arrows show in this study that, again, knee extension, which is the quadriceps muscle, had a huge decline by a 50% change in over 4 years. And the other muscle that had a 50% decline was ankle extension, which means your foot dorsiflexors. Those are the muscles that cause a foot drop in IBM. Again, appreciating that some muscles have much more of a decline than others. So that's the left side of the chart. And then here, again, the last line looks at the IBM functional rating scale. And you can see in a 4-year period, there is a 22% decline in the IBM functional rating scale, which means that maybe our clinical trials to look for a drug effect shouldn't be 1 year where we're looking for a 2% change, but maybe a 2 to 4 year trial would actually tell us if a drug is working, because we could see a larger degree of change. I know that won't happen with pharma, but it's still certainly something to think about, right? And then the graph here on the top, where it says it's a 30% decline over 4 years, is actually summating and averaging out all the muscle strength scores. and then it looks at the decline over 4 years, which is about 30%. And then some trials have used what's called the 6-minute walk test, where they measure how fast you can walk over how long you can walk over a 6-minute period. And what I thought was interesting of this graph, so yes, they said that in 4 years, you might have a 30% decline in your walking ability. But if you look closely at this graph, what you'll notice is that some patients on the top, right here, this group, didn't decline much. And this bottom group, you're seeing much more of decline. Well, this I think really highlights, which the study didn't even talk about, but we do have a subset of patients that don't have much of a decline in walking. And then you can see a percentage of patients that do have a major decline. So again, what I was talking about is that I do think IBM is going to fall in the spectrum where some patients do have slow progression and others may be progressing faster than we appreciated. Does everyone see what I'm talking about? Okay, thanks. Again, the Zoom is, all right. And then what I also wanted to highlight was this was a study that looked at assistive devices. So, some of my patients ask, well, what does my 10-year situation look like? What does my 20-year situation look like? And so I was trying to look at some literature that could give us guidance on what does that look like. This is just looking at 50 IBM patients and what devices they are using overall. And you can see here that 63% of IBM patients use some degree of device. If it is a brace, if it's a walking stick, or if it's a wheelchair. 14% used a brace. 59% of patients used at least one walking stick. And about a quarter of IBM patients in this study, or 25%, used 2 sticks. Many of my patients want to know about wheelchairs. So, am I going to become wheelchair dependent? What does, it look like? Well, this study, again, just 15 IBM patients in the first study, said that 47% of patients were completely wheelchair dependent, but this was about 7 patients in their study of 15. So again, I don't want to make large generalizations because I do believe that IBM is the spectrum of a disease. But look at what's important to note is the disease duration. So patients that were wheelchair dependent had this for 20 years. Now let's go to the bottom line where this study looked at 106 patients. And they actually said only 1% of their patients used a wheelchair. But the time they were evaluating these patients was only over a 5-year period. So I do think disease duration does play a role, but that's not the only answer we have as to why some people are wheelchair dependent and others are not. But I just wanted to show you the spectrum of even what's reported in the literature. Importantly, this is the only study that looked at survival in IBM. So I think this is important to note. This was a study out of the Netherlands with looking at the Dutch population. And they did a 12-year study. In the study, there were 64 patients. 46 of them passed away because they were at some period, they had the disease for 20 plus years or more. But the median age of death in their study was 81 years, and the average life expectancy in the Dutch population at the time of this study was only 79. So what they concluded was that an IBM patient does have normal life expectancy. There hasn't really been any subsequent studies looking at survival. But importantly, which a lot of my IBM patients remind me is, sure, I'm living longer than, other patients with other diseases, but I have greater disability. And I do recognize that and appreciate that, and I hate that for my patients. But I think it's also important to look at, well, what are the leading causes of death or significant illness in IBM? And respiratory or aspiration pneumonia is actually the leading cause. In this study, 41% of patients who passed away passed from aspiration pneumonia or some issues, which we'll talk about because I do believe these are preventable things that we can be proactive about. And then the other less common, only 6%, but still prevalent, was cachexia, which means muscle wasting and muscle loss and poor nutrition. Again, something that we could try to avoid with better nutrition. So, which brings my point to multidisciplinary care. In our clinic at UC Irvine, we do have a multidisciplinary team that does evaluate our IBM patients, and I do think it's very helpful for IBM patients to have not just a neurologist and a rheumatologist, but actually a care team. And it doesn't necessarily have to be in one setting. You can be proactive about asking your primary neurologist or rheumatologist to see some of these specialists. And we'll talk about in these upcoming slides what each one of these individuals do for IBM. So in our clinic, when we are evaluating our IBM patients, every visit, we typically like to see our patients every 6 months. And that's because in between those 6 months, typically we don't see major changes. So we don't want to waste your time by coming in constantly and saying, oh, we don't see any major change. But we do evaluate muscle strength, and we actually have a number of muscles starting at the shoulder, down to the hand, and then again, starting at the hip, down to the feet, that we actually score on a 0 to 5 scale. And most neurologists will do this, where they will give you a score. And what we do is we're looking back and seeing how have those scores changed. So it can give us idea of how fast is your muscle weakness progressing. Are you doing great because we're not seeing a change, or are we dropping on these scales every year that we're seeing you and you're progressing faster than we'd like? Also, very important to ask about walking, fall risks, if you need assistive devices. I always ask about function in your home. I actually loved it during the pandemic when we were doing these Zoom visits, because patients would actually show me how they get up from their own bed or their own chair, and we would give tips and insight into what can we do better to make this better for them. So I think function of just your daily activities are really important looking at, because we're trying to prevent falls, and falls make us prone to fractures, and fractures put us at even greater disability. And then swallowing function, like I mentioned, is also really important. So when I see my patients on a regular visit, these are all the main important features I want to ask about. And if your neurologist or rheumatologist doesn't ask you, you can tell them about all of these issues. Some of my patients say, oh, I don't need any other doctor. I have you. And I love our relationship, but I do think a primary care doctor is very important, because age-related health screening is still very important in IBM. As we get older, other medical issues do arise, and you do need to see your primary care physician routinely. Getting bone density tests periodically can be helpful, especially if you have a lot of muscle wasting and a lot of weight loss, because that can impact bone health. And then if you're not feeling well, this is when you check in with your primary care doctor, because there are occasions where patients that, have just tremendous weight loss and muscle wasting may not mount a fever. So making sure you don't have an infection, regular vaccinations, and then something that I think we don't do a good job talking about in healthcare overall is mood medications. If it's for mood stability, if it's an antidepressant, I think anyone dealing with a serious medical condition or a significant medical condition sometimes needs help. Sometimes they need help. The caregiver needs help. The physician could need help, but it might be helpful to really ask yourself, do I need something to help with? And if it's depression, if it's mood, and your primary care may not bring it up, but if you bring it up, they will certainly help you. And there's a number of antidepressants out there these days that they're probably the best resource for that. And then a pulmonologist or a respiratory therapist is very important in IBM. So even if you don't have breathing difficulty, we like to see regular assessments of what your pulmonary function tests look like. Now, I'll just remind you, unlike some of the autoimmune diseases that have lung involvement, IBM does not have lung involvement. However, they have diaphragm muscle involvement. And diaphragm is a muscle that does get weak in IBM, and it's probably underappreciated, and maybe some neurologists and rheumatologists don't even routinely check for it. But we like to do pulmonary function tests anywhere between 6 months to at least annually for all of our patients. And what we look for is, do they have any signs of diaphragmatic weakness? And it can be difficulty laying down flat, like some patients will tell me they need 2 or 3 pillows to sleep at night. And that's because you're actually supporting your diaphragm by doing that. When you're completely flat, the diaphragm is most challenged, and that's where we'll see diaphragmatic insufficiency, but that's where we can pick it up. Some patients will just tell you, I feel very tired all the time. That could be a sign of, yeah, sure, your muscles are weak, but it could also be because of carbon dioxide retention. So when the diaphragm is weak, we can't expel carbon dioxide and get a good breath of oxygen because it's a little bit shallower. And so if you're retaining carbon dioxide, that actually seeps into the muscles and can cause muscle pain, muscle fatigue. So anyone that tells me I'm a little tired, we will make sure to check their pulmonary function test. And then, there's prescriptions for it. So if the diaphragm is weak, just like people have sleep apnea, there's a machine called BiPAP, where similar to CPAP. In neuromuscular weakness, we use BiPAP, and BiPAP helps that diaphragmatic movement so that you are expelling the carbon dioxide and getting in the oxygen you need. People sleep with it. Universally, I hear, I hate it. I can't use it. I've tried it just to know how it feels. And it's hard to use, I understand, but it is practice. And some of my patients that can't use it, I'll say, well, you're supposed to sleep with it. And if you can sleep with it for over 4 hours, that actually can benefit you. I'll tell people to even just try it while you're watching TV so you can get used to the mask and the pressure. And then once you start getting used to it, then start trying to sleep with it. The other important thing is if the mask doesn't feel right, call the respiratory therapist that delivered the BiPAP. They can always check the settings, make sure your settings are okay, the flow is okay, the fitting is okay. And if the masks need to be adjusted, there's a picture here of different masks that are available. And then lastly, cough can become weak in IBM. So we all give a good cough to expel some deep-seated secretions, but over time that mechanism of cough becomes weak. There is a device called a cough assist device. I call it almost pulmonary toileting or something to use as daily hygiene. So it helps clear these deep-seated secretions. And those deep-seated secretions are what puts you at risk for an aspiration pneumonia. So you might not have like a severe choking episode to cause a pneumonia. You could even just have mild secretion buildup that over time gets into your lungs and can cause a pneumonia. A cough assist device can help clear that. And actually, studies have shown that a cough assist device helps reduce the risk of pneumonia and tries to even help strengthen the diaphragm. So almost like an exercise for your diaphragm. So if you don't have that and you do have a weak cough, something very helpful to ask your neurologist. We have a speech swallow therapist in our clinic. I had mentioned in an earlier session that what we like to do is what's called a modified barium swallow. That's a picture you see in the top right corner. They give you something to swallow, and then they take x-rays while you're swallowing to see how significantly, or if at all, your swallowing is affected. Or even if you have what we call this bar that can develop in your swallowing mechanism that obstructs your swallowing. And that's why some patients talk about a stuck sensation when they're swallowing. All of that can be potentially treated or at least evaluated. So having a barium swallow is important. I like to do this in almost every IBM patient, at least as at baseline. And then, over the years, as we're discussing, if we're seeing that swallowing issues are changing, it can be repeated. It's not something that needs to be done every year, but every few years if things are changing. Our speech therapist will give you mechanisms on how to swallow better from maneuvers such as what's called the chin tuck, where that helps swallowing. She'll talk about thickeners, where there's a thickener available, so because thin liquids sometimes can make people choke. So there are methods and interventions that are used to try to help the swallowing mechanism. And then, like we talked about in prior sessions, there are other interventions, more surgical, that we can do, like what's called a dilatation, where they stretch the muscle, but it's not permanent. And after a few times of doing it, it actually puts you more at risk. So it's not recommended to do more than about 3 times. And then what Dr. Nadaf had mentioned was the cricopharyngectomy. Again, we don't do this universally in patients. However, if swallowing issues become severe and there is an obstruction or that bar that we saw on that swallow study, that's something that can be considered. And not common, but a small percentage of IBM patients do develop such severe swallowing issues that a feeding tube is required. And the way I look at it is if we reach that point, again, not common in IBM, but can happen, it is important to address because a feeding tube can help with hydration, it can help with access to pills, and of course, caloric intake and nutrition. And we want to avoid that muscle wasting that happens from severe weight loss. And then lastly, you'll probably hear in some IBM patients, speech issues become more difficult over time, and the clarity of speech is hard. And in those patients, we actually do have communication devices that are available from, technology that they can type something. There's actually even devices, what we call an eye gaze, where if finger movements become very difficult and typing is hard, we can use pupils as a mouse tracker to press on a laptop and help speak different sentences for you. So there are mechanisms to help with speech. I think the gentleman back there had a question.
Just to show you how things happen in real time. You talked about modifying the diet. It also includes modifying the food. If you notice today during your lunch, chicken was cute. That's some direct feedback that people were having a hard time. With IBM, we have to probably just So we did the recommendation that they work with the hotel staff.
Yes.
If possible, use it.
Yes.
So your feedback is appreciated, and modifying your diet and the types of things that you eat is important. But it's a real-time issue.
Yeah, and I'll just repeat the question. I was asked to repeat any question for the recording, but the question was about, or comment was about modifying the diet, and that's a really important, helpful point, is that you'll notice that you're starting to avoid certain foods. I'll actually always talk about foods with my patients, and they'll say, oh, I don't have any swallowing issues, but then my next question will be, well, are you avoiding certain foods so you don't have swallowing issues? And many people will tell me about dry foods, toast, certain foods like soft foods will be easier. And so you do have to ask yourself what is working and what is causing some of the coughing, the choking. But that's great. Thank you. And then we have a physical therapist on our team, and I think someone in the general session made the comment about physical therapy, and I completely support and echo the thought of physical therapy and occupational therapy. But there are several roles that a physical therapist can take a deeper dive with you about what are your risks of falls, what adaptive equipment do you need? Is it just braces? Is a walking stick perfect? Do you need that walker? How does your home look like? So our physical therapist actually makes appointments with our patients to go out to their home and evaluate their home for safety. Do we have railings? Do we have grab bars? Do we have a shower chair? Do we have things to make your home safe? Are you climbing 2 flights of stairs every day to get to your bedroom? And should we think about modifying the home even to put your bedroom on the first floor? All important questions to ask yourself. And I do see people taking notes, and I just want to remind you that all of my slides have been available on the website, so you'll have access to all of these slides because I want you to have this information. And then the role of exercise, I think you're hearing it over and over again, but we all believe in exercise in IBM. And from if you're mobile to if you're wheelchair dependent, exercise makes a tremendous impact on your condition. If it's something from stretching or range of motion exercises to even light weights, but doing some form. And I tell this to all my patients, but no pain, no gain is not the motto here. So we're always taught in elementary school, let's exercise till our muscles hurt. In IBM, we don't want to cause significant muscle pain. I appreciated your comment, I think earlier, where you talked about thigh muscle edema, and I personally would be worried about that. So if you have significant swelling or pain in your muscle, for me, that's a sign that you want to back off. One of the physical therapists here said it, I think, great, is that you do start slow and you do go slow and you figure out what's working for you. And the next day, if you're in pain, you're doing too much. And nutrition is also really important. So if you are noticing that you're having significant weight loss, ask for a nutrition consult. In our clinic, we don't have a nutritionist per se, but we have an access to a nutritionist. And if there is severe weight loss, I do recommend seeing a nutritionist. They can help you with calorie intake for sources of food that have high protein. And we had mentioned again in the general session that constipation can be a major issue. I see it especially in IBM patients. Our bowels like movement. So as you probably think back to when you were walking fast, the bowels were moving. And as we slow down, so do our bowels. And so constipation can be a real issue. helping it with fiber supplements, berries, asking your primary care doctor and your caregiver about other things that you can do to help with constipation is something that should be addressed. I tell all my patients they should have a bowel movement every 3 days. And if you're not, at least every 3 days. And if you're not, an intervention should be done. If it's a suppository, if it's increasing supplements, finding a way. And I realize I've been talking a lot, so I'm going to go through, I'm on my last slide, but a social worker can be a very helpful resource. IBM is hard, and IBM is hard for you as a patient. It's hard for you as a caregiver, and there are caregiving resources, disability insurance, home health services, support groups have been a tremendous resource. I've actually gone to many TMA local support groups and learned from them and what patients are even telling each other. And I think it's a wonderful resource if patients haven't been to a support group. Finding your local support group can actually be very helpful. And in the era of Zoom, I think a lot of these support groups even meet over Zoom. And so you can do it in the comforts of your home. And so this is my last slide, but a study was done in ALS, and they actually proved that patients that went to a clinic that had multidisciplinary care had better quality of life and had less falls, less fractures, and less hospitalizations. So you don't always have to go. I know access to these specialized care centers can be hard regionally, but you can empower yourself by asking for some of these things in your care and making sure they're done. And I'm happy to take questions and answer anything, but I hope that gives you a little bit more insight. And I really want to thank you for the 17 years I've taken care of IBM patients. I've learned from you guys, and a lot of these tips come from my patients themselves.
Did you graduate when you were 12?
I hope that I still look like that. Thank you.
My question is, so do the stretching, you do the aerobic, you do the balance, do the strengthening. I see a speech person who wants me to do voice and swallow and breath. I have an OT that wants me to do hand. I have somebody that said I should do nerve flossing. I like that's my full-time job.
Yeah.
Like, how do you, like, but it all feels important. Like,
Yeah.
it's a function, so it's all important. So, and they all want it every day.
Yeah. Yeah, that's a great question. I mean, it almost becomes taking care of yourself becomes the job now, right? But I think that's a great question and something you do have to focus on. Making it a part of your daily routine and your daily hygiene helps, right? Stretching even 15, 20 minutes goes miles, and you owe yourself. The way I look at it is if you can exercise 15, 20 minutes, we all owe ourselves 15, 20 minutes in a day where we can tell ourselves, okay, I'm going to do a stretching routine. I prioritize exercise. Swallowing function is something you're doing, even as we're sitting here, we're swallowing our saliva. So swallowing is something that I wouldn't say you have to necessarily go to therapy for, but you have to make a conscious effort to recognize the foods that are causing problems versus not. But I wish I had a time, a frame where you could just walk in and add more time. I think that's what we're really looking for. But exercise doesn't have to be 1 to 2 hours. It can even be 15, 20 minutes and starting with that. Yeah.
Can I ask how many people still work and have IBM?
So the question was, how many people are still working and have IBM? So, Yeah. Yeah, in the room it was about 4 or 5 people, and it is a struggle. And patients ask me that: should I be on disability? Should I ask for medical leave? And I think my answer back to patients is, I want you to do what truly makes you happy. Some patients feel like work is important to them to the point where, they don't want to let that go. And so we want that for them. And some patients say, I want to make, my priority just doing physical therapy and just spending time with my family. And that's what's important to them. So there isn't really a right answer. What I do caution people is, if you have a physical job, we don't want you to have a job where you're causing muscle pain or muscle fatigue. Yes, sir.
I just wanted to add, I have an ADA request for when I work, so I work 40 hours a week. One, I work at a computer, so it's not uber physical, but I work remote in the mornings, so that's the hardest, and I work remote on Friday. But the one that helps more than that is I get 2 20-minute breaks throughout the day, and now I have it where I can combine those in any way I want, along with my lunch, so if I need to take a break to rest my fatigue, I can, as well as I have in place, if I ever get a flare-up, I can then go home and work remote. But I had to fight very hard to get the company to agree to that. So,
Yeah, that's a great point. There's a comment on, again, for the recorded audience, there's a comment on rest in between basically activity. If it means work, or if it means, multiple chores and activities at home, I think rest goes miles in IBM, and not pushing yourself through that major fatigue that you're feeling actually is very valuable. Listening to your body is sort of a key, where if you do pause and stop for 15, 20 minutes, you will notice a rejuvenation, and you can sort of prolong that. Another helpful tip I give my patients is, patients hate the idea of a wheelchair, which I totally respect. But if you are going long distance, or if you have a day with your family where you're traveling, or you're at an amusement park and you have to walk a long distance, or you're at a mall, being in a wheelchair or even a scooter helps conserve energy. And so when you get there to your destination, you actually have enough energy to do the activity with your family that maybe walking there would have tired you out. It could be from the parking lot to an event. And so using those assistive devices that conserve energy actually will go miles too.
One of my support people suggested I look at an energy budget, and so I have a finite amount of energy in a given day. How do I want to spend that?
Yeah.
So days that I have lots of clients, important things, that's when I do squats right every time I get off the toilet, instead of doing squats with my therapy.
Yeah.
So, those are the kinds of things we have to start thinking about as part of our adaptation in life.
True. A comment's made about just asking yourself how to conserve energy and what activities are, where you want to expend your energy is insightful to yourself. Yes.
You mentioned staying current on vaccinations. Are you recommending the new RSV vaccine and pneumonia and the latest COVID?
Yeah, I think in IBM patients especially, unlike, some of the patients in the town hall that were talking about autoimmune issues and vaccinations, for our IBM patients especially, we recommend all up-to-date vaccinations and age-appropriate vaccinations. With the diaphragm being compromised, there's always an increased risk of pneumonia, and it can always hit you harder. When COVID first came out, we were worried, just in general, we meaning the neurologists, rheumatologists taking care of our patients, especially with diaphragmatic weakness, because we worried that if they got sick, if their diaphragmatic weakness and their breathing muscles would get hit harder. So we still are very passionate about making sure patients are vaccinated. Great question. Yes, sir.
Have there been any studies done regarding IBM and the amount of cases here compared with other countries or even other areas of the country here in the U.S.? Like is the West Coast more prevalent to it or as compared to Canada or France?
So the questions about the incidence of IBM and prevalence of IBM in the U.S. or even regionally versus other countries. And there haven't been like systematic comparisons, but there are studies from different regions, like Minnesota has a publication about their prevalence of IBM. There is prevalence in Australia. There is prevalence literature in the Netherlands. So, but I wouldn't say that anyone's sort of done one globally across the world and said which countries or which ethnicities may have more prevalence. We are looking at ethnicity in our natural history study, and I think because the natural history study that we have in the U.S. is covering 13 different centers around the U.S., we are going to look to see about if there are variations in that. So hopefully in a few years we'll have those answers for you.
Thank you.
Right? Yeah.
One thing I
Thanks.
noticed about the adaptive equipment, there's a company called Lifty, and they have a power lift off the toilet. And I found that to be the best tool I've gotten in a long time. If you have any trouble with that, you ought to look for it.
Yeah.
It's like get chairlift and then get the bidet with it. It's absolutely incredible.
Yeah, great point. Yeah. Yeah, very helpful tool. You know, I have a lot of IBM patients. If their weakness, is in that hip area or they're having problems getting up from standard chairs, they'll actually carry around major cushions. You've probably even seen some IBM patients have it here in the conference, but they bring it to restaurants, they bring it to doctors' offices when they have these low chairs because it'll help them get up from a chair. Yeah. Yeah.
I have a question about stress and the role of stress on the muscles and the breakdown of muscles. If you have a job that's like high demand, very stressful, not physically but mentally, ton of clients, demanding timelines, is that something that can be used for disability purposes? Like if that stress is breaking down your muscles faster and making your disease progress? Does anyone here know if that would even qualify for disability because of the stress?
I would not use the stress as a reason to get disability, but I would certainly just use the disease itself. IBM is enough to say that you have a progressive muscle condition. And honestly, when my patients come to me and say they want disability, I will write out the forms to say this is progressive, this is a severe muscle condition, they have difficulty with fatigue, with weakness, because unfortunately insurances or other systems won't recognize stress. Between us, though, I definitely appreciate what you're saying about stress, and I do think stress impacts any medical condition, and certainly we see it in neurologic conditions, that the more stressed someone is, the harder the impact it is on IBM. Yeah. Yes.
I was thinking too, along that, you're just using the IBM, it's really a danger for them, because if you fall now, they're at risk of being
Right.
sued. So, just the fact that it's a progressive muscle weakness, that,
Yeah, I usually write on the forms. That's a good point. I usually write on the forms high risk for falls because then they start worrying too about, the liability issues. Right. Yes, sir.
I appreciate that earlier in the presentation, you talked about looking at growth to treatment. I think emphasizing the importance of real side, because just like with the thing, when you decide to see your push or
Oh yeah. So I think you're asking, and correct me if I heard you wrong, but you're asking about physiatrists or physical medicine rehab specialists as part of your care team. Probably the only reason I didn't list it is that they're not commonly part of the care team, but if you find a great physical medicine rehab specialist, they should be part of the care team. There are some specialists I know that are actually trained both in PM, we call it physiatry, and in neurology, and I think they're very valuable. So I do know of specialists in the country even that have that understanding. When we train doctors that have either become neurologists or rheumatologists, but when we train them to understand IBM, some of the specialists we look at are physiatrists to come under our training to understand IBM. So I absolutely think physiatrists would be a great option too. Yeah. Yeah.
My insurance company only allows 40 physical therapy sessions a year, and I have maxed out. Can a doctor prescribe more that possibly they would recognize beyond my norm?
So I just heard in the prior session.
Did Musafar send the article to you?
I haven't had a chance to look at my email yet, since, but
There's case law. Are you on Medicare?
No.
Okay, well, when you get on Medicare, there's case law, eventually, when you age to be mature enough for Medicare, there's case law that shows that we get Medicare pays for our physical therapy in perpetuity because it's maintenance. And we don't have to do the BS of, only so many and not enough, but it's never, because it's never enough. And we need it forever.
so
Case law, give me, people who are qualified for Medicare in the
Yeah.
United States,
I quite, just make it.
okay. Apply for your Medicare, and then, if you want to give me your little card, I'm sending the article to folks who are interested. There's case law, which means, I don't know if it's, I think it's ruled for, against, yeah, the patient versus somebody, their Medicare.
maybe you can even send it to the TMA, because then they can put it on their website. I think that's a helpful resource, but from what I'm hearing, they will allow endless physical therapy. Uh-huh.
Probably non-Medicare, though, it's going to be up to the insurance.
Correct. Yeah, I mean, what we've seen, at least in the past, is if they're not Medicare, they sometimes will renew it. They will allow it for like a 3-month period or 12 sessions, something like that. And then you have to pause a little bit and then give a sort of a reason for renewal. And I definitely like all IBM patients to have routine physical therapy. It's sort of like this is our one pill we do have. Why not? And we have access to it, so why not do it in whatever shape or form? And probably one thing I didn't get to spend enough time on is but the types of exercise. My favorite 2 exercises I'll recommend to patients are water therapy. So if you can get in a pool safely without risks of falls or hurting yourself, the pool eliminates gravity, so it really allows you to move much more freely than you could, without the pool. And stationary cycling, if you can get on a bike safely. And if you can't, especially in the era of the pandemic, a lot of times I heard our physical therapists recommending stationary pedals, which you can buy on Amazon for like $20 or $30. And at least while you're sitting and watching TV, you can pedal away. And even just that movement, that circulation, helps with the blood flow to and from many muscles and can do more than you think. Yes, sir.
Just to reinforce the point about Medicare, it does not limit the number of physical therapy sessions you can receive in an outpatient setting. However, in an inpatient setting,
Yeah. So if I heard you correctly, it was physical therapy is not limited with outpatient, but in an inpatient setting, which it's the outpatient setting that applies to most of our patients. So that's great. Thank you. Yes.
yeah, just a question, IBO may be included in the American Disabilities Act. IBM. Is it included in the ADA, American Disabilities Act?
Does someone know?
Well, it falls under the muscular dystrophies. You know, the main thing is getting your doctor to write up
Correct.
appropriately, and then ADA.
Yeah, I think some key words to give your doctor is progressive muscle weakness, progressive disability, risk of falls. Those are key words to give your doctor when they're doing the disability write-up. Yes.
Steady so that you can maintain your daily living activities. It's also one of the key things so I can get in and out of the chair, go to the bathroom, get in and out of bed safely.
Yeah.
That's why the IBM, we have no medications or anything, but that physical therapy once a week or every other week keeps those going. That's why they kind of come down with that.
Yeah. Great. Yes, please.
Anybody who lives in California, in-home support services is covered under Medi-Cal, which is covered under Medicaid. And in California, to qualify for Medi-Cal, you have to, your home does not disqualify, doesn't count in the exclusion. Your home, any of your retirement accounts, any of your trust accounts. It's your personal assets. You can have personal assets that don't include those other things of $130,000. And a lot of other states, it's like $2,000.
Yes, ours is 2,000.
Yeah, and so that changed last year. And in California, we had a Medi-Cal consultant come to one of our Zoom meetings for the California IBM support group. And a bunch of us have been working for the past few years, shift our money around so that we get in-home supportive services at less than $50 an hour.
Great.
Which is significant.
Yes. That's great. See, this is why I like coming to these meetings. I learn just as much as you guys learn. That's great. Thank you for the helpful tips. And I hope this session was helpful. But great to see you guys. Thank you.